Thank you for the kind introduction, and also for all of you coming along and the opportunity to talk to you today about a topic that we all hear a lot about. There are very few facts about, and really, you know, there's an awful lot more misinformation out there than there is information. It's a very difficult area for patients to find their way through, and so hopefully by the end of my talk you'll be a little bit wiser. We're slowly getting to learn a little bit more about this. So the topic is vitamin C. You'll also hear me talking about it as ascorbate. They're both the same compound. So what is it we're talking about, and why are we talking about it? Well, vitamin C, for us, it's a vitamin. That means it's something we have to get through our diet. For most animals, they make their own vitamin C. They make it in their liver. They don't need to get it from their diet at all. So it's for us and a few other species, this is a vitamin. So it's something that we get from food, and only from food. So we have to take it in. And when we eat basically fruit and vegetables, it ends up in our circulation, and it goes from there all around our body. And from there, from the blood supply, it gets taken up into all the cells in our body. And this is where vitamin C is active. So it's not active in your blood, it's active inside your cells. And the blood is just a transport mechanism to get it around. Now, how much gets around depends on how much you eat. And so plasma levels can go anywhere up to 100 micromolar. Anything over and above that will just get flushed out through your kidneys. So how does our population fare, basically? So it depends on how much you take in. Now, what we believe is that for saturation to occur in your body, so for all the tissues to have as much vitamin C as they want, which we think is probably what they need, you need to have a plasma level up around here, 70 to 80, anywhere between over 60 micromolar. This is a general population from New Zealand, taken from the electoral roll in Christchurch, 50-year-olds, and you can see that our general population, not many of them are around here. The biggest proportion, and this is very normal across the Western world, the average is about 50, so that's below saturation. We've got a big proportion of people who are not eating enough fruit and vegetables. So we know the 5+ a day, but it really pans out here. That's the healthy population. There's an even more complex situation when you get sick. So remember that same scale along the bottom. So these black bars here, these are people, all sick people on day of admission into hospital. So anyone sick with anything, on admission into hospital, you can see that a whole big proportion of people coming into hospital have circulating vitamin C levels getting close to scurvy levels. Now, this is not at all unusual. When you get sick, your body's using a lot more vitamin C than normal, and so if your intake's not increased, you start running out, and a lot of people come into hospital quite ill or quite deficient. Hospital food doesn't help, I don't think, but well, certainly not if you live in Dunedin, apparently. But anyway, so how would this impact on a tumour, and why are we interested in vitamin C in cancer? So we know about it in terms of supporting our general health. And we got interested in this in about 12 years ago, I guess, when it was discovered, so 15 years ago, a factor was discovered that describes why cancers can survive as organs. So why does a tumour, with all the genetic information that we have, why does it actually grow into a tumour? And it seems that one of the things that enables a tumour to grow is its response, its ability to be able to respond to the stresses of a rapidly growing organ. So one of those stresses is that the tumour outgrows its blood supply. And so you can see here These are new blood vessels, and this is the centre of a tumour. There's no blood vessels in there. So as those cells divide really quickly, they outgrow the blood supply. They run out of oxygen. And that response to running out of oxygen drives the formation of new blood vessels. So if they can't do that, if these cells can't do that, they can't grow bigger than 2 millimetres. So a tumour can't grow unless it can do this. This is a normal response. So we call this is the metabolic response of the tumour. The other pressure that they're under is the rapid growth. So in order for cells to grow rapidly, they need to have a whole different metabolism inside. They need to be channeling their energy through alternative sources, and they need additional food. So for all of those things, they need what we call a hypoxic response, which upregulates their ability to survive that rapid growth and the lack of nutrients. And this pathway is controlled by this protein, which we call HIF1. Now, HIF1 drives a whole lot of responses that we know. This is a typical response for cancer cells. These are the hallmarks of cancer. Cancers form new blood vessels. They can metastasize. They're resistant to treatment. They grow rapidly, and they're glycolytic. That means they need sugar for energy. All of these things we know. This is what a cancer looks like metabolically. And this is driven by a normal response. This is quite aside from the genetic thing that's driving the rapid growth in the first place. So there's a marriage of genetics and normal metabolic response. It's all driven by this pathway. What's vitamin C got to do with this? Well, it turns out that vitamin C is a big off switch for this pathway. So one of the things it does in its normal activity in our body is it keeps this pathway off. And so we only want this to come on when it's absolutely necessary. So the less vitamin C you have, the more likely you are to switch this on. And we want this off. So what happens when it's off in a cancer? So these are tumours growing in a mouse. So if you don't have that HIF pathway active, you can see the normal tumours grow really rapidly. So this is the growth rate up here. And you can see if you don't have that metabolic response, you've only got the genetic effect, the cancer's growing much more slowly. So not only is it growing slowly, we also think it's much less likely to metastasize, and it's much more susceptible to treatment. So also we know that in people, if you have a cancer that has a low HIF1 activity, you have a much better prognosis than if you have a high HIF1. This is for tongue squamous carcinomas. It's true for pretty much all cancers that are driven in this way, and most solid tumours are driven in this way. So the less of this you have, the better the prognosis for the patient. So then we come to this man. This is where so vitamin C, you'll all know, this has been really controversial with respect to cancer treatment, and there are people raging with debates, I say, on either side of me. We are not involved in either of those debates. We want to understand what's going on. But this man was an eminent scientist and also a double Nobel Prize winner, got very interested in vitamin C and cancer in his later career, and made a bit of a crusade of it. So at the time, which was in the 1970s, nobody had any idea why would this work. And so it became kind of like an impossible thing. How could such a thing possibly work? No one had any idea what kind of mechanism could be involved. And really it wasn't for another couple of decades that we started to learn about HIF1, and we thought, well, actually, maybe there are some mechanisms and something about vitamin C that we didn't know before. So Linus Pauling gave people intravenous injections of vitamin C, and everyone in this room will have heard of people who have done this, or you can go out and get this, get this treatment. It's not regulated at all. Is it any different than taking oral vitamin C? Turns out that it is a lot different. So if you take oral vitamin C, your plasma level will never go up above 100 micromolar. With the injection vitamin C, you bypass the gut control, and your plasma levels can go up hugely depending on how much is injected. Now, no one had any idea, does it actually matter if you do that? But we know there's a difference between those two treatments. We're coming round to think that there may be something in this, and there may be times at which that's useful. There's also times at which that is absolutely not necessary, and oral vitamin C is a much better and certainly a lot cheaper thing to do in terms of personal benefit. So we want to know, well, is there anything we can actually find out about this? And we've done a whole years of experiments looking at human tumour tissue, and we had our speaker earlier talking about the big tissue bank in Nottingham. Well, we've got a huge tissue bank in Christchurch as well that's been collecting samples for over 10 years. And so we thought if we analyse that tumour tissue and we ask the question, are vitamin C levels in the cancer, are they limited in cancer tissue? And are they associated with how much HIF1 is active in those tumours? And so this is Helen Moran, who's our super curator. And so this is the Christchurch Tissue Bank. They have all of these different cancers stored, different numbers of the different tumours. And so we've analysed 4 tumour types to date. We've got ovarian cancer, kidney cancer, breast cancer, and bowel cancer. And we've analysed a cohort of all of those cancers. And also this bank has normal tissue from each patient. So we have tumour and normal matching tissue from each patient. So we've been able to compare the tumour to the normal. And so what we do is we measure things. And so we've ground up those bits of tumour tissue. So they get ground up on ice. And then we've measured vitamin C, HIF1, proteins that it regulates, and the number of cells that are there. So we're getting numbers on what's happening in that tumour, in those tumours. So the first thing we note is that all of these tumours have HIF1. So this, like we saw previously with immunohistochemistry, you get this brown staining where the protein is present. And you can see here it's present in all little dots, which means it's inside the nucleus of the cell. So that means it's there and it's active. So we're seeing this in all of these tumour tissues. We don't see it in the normal tissue. So that's typical of cancers. And if we split all of those tumours up into high and low vitamin C levels, then this is the low vitamin C levels, and endometrial cancer has more HIF1, and the HIF1 pathway is active. In endometrial cancer, if you've got vitamin C is high, it's low. The same in renal cancer, so in kidney cancer, low vitamin C means high HIF1, and vice versa. In colorectal cancer, the same. And so, and also with our colorectal cancer patients, because we've got long-term survival on this patient data, those patients that had high vitamin C at the point of surgery in their tumours had a much better survival rate than those with low vitamin C. This was independent of the grade and stage, which you heard about before. So it didn't matter what grade or stage you were with this variable, that by itself, which was, so these patients have had no intervention. It's just probably reflective of their dietary intake and their tumour type, probably. How much vitamin C is in the tumour influences the outcome. With breast cancer, with our breast cancer cohort, we see the same picture actually. So with the HIF1 level being lower when you have higher in the high vitamin C samples, this protein which is regulated by that is also lower. If you put them all together, then the HIF1 is lower when you have high vitamin C. And also this is the amount of transporters. So these seems like the vitamin C cells are actually like hungrier for vitamin C as well. So looks like they're trying to get more. We see that with grade, and you may remember from the earlier talk that the high-grade tumours are really irregular, so they're highly disorganised, and so the low-grade tumours have a much more defined structure, and it seems that the higher grade the tumour, the harder it is for it to get hold of vitamin C, so those vitamin C levels are lower. And that also relates to how much necrosis there is in the tumour. So that's a measure of like the aggression of the tumour. So those are that are more aggressive with the lower vitamin C. And tumour size is also related. So the smaller tumours had the higher vitamin C levels. So we see this with all the tumour types, and it's also true of breast cancer. Now, so that's kind of a prognostic indicator. What we see with vitamin C therapy almost across the board. So people, we have this anecdotally, and there's more and more evidence emerging of this, that overall survival is like if you're taking high dose vitamin C, it's going to have a much smaller impact on your overall survival. It will have a large impact, on quality of life. And there are lots of studies showing this now. And I'm just going to give you one case study that we looked at, which refers to that. And so this was a patient in Christchurch with invasive ductal breast cancer, and so she was had secondary breast cancers, was on chemotherapy, and with lots of side effects and feeling extremely low. She went along for intravenous vitamin C sessions twice a week, with a bit of a window between that and her chemotherapy. And she did these quality of life questionnaires. And this is just to show you what kind of dramatic effects you may see on quality of life. So these are fatigue scores before and after. So the black bars being before, and so you can see measures of fatigue coming down, nausea and vomiting coming down, pain coming down. This is breathlessness, appetite loss, constipation, and diarrhea. So a lot of things disappearing in terms of social functioning. So the global health status is up, physical functioning's up, role functioning, so better able to do everything, emotional functioning, cognitive functioning, and social functioning all up. So overall, this is an overall score. So you can see particularly the fatigue scores coming right down. So this is a very typical, I would say, response from people who are suffering side effects of chemotherapy. And just thinking back on that, so think back on that earlier graph that I showed you of those hospital patients coming in. So a lot of people who are sick and undergoing treatment have extremely low levels of vitamin C. I'm just going to show you. So we've got, quickly, we're currently doing a human intervention study where we're looking to see, so does people get these high-dose vitamin C, does it actually go anywhere, and does it actually do anything? Believe me, no one's ever looked. Lots of people are given this treatment and nobody looks. Yep. First of all, so we've recruited about 15 patients and 6 control patients. First of all, of our recruited patients, when they come in, so these are people coming in with a suspicion of colorectal cancer. They're still at work. They're still, supposedly, feeling okay. They score well on all their quality of life scores. At diagnosis, 2 of them have scurvy levels out of the 13. 2 are marginal, so marginal for scurvy. 7 are below adequate, below the 50 micromolar. Only 2 are within the adequate vitamin C status. Several weeks later, just before their surgery, they've had no treatment or anything in the interim. 2 are still deficient, 5 are now marginal, 3 are not adequate, and only 2 are still adequate. So people are coming in with really low levels. Well, I mean, these are surprisingly low, much lower than the general population. And they fit this. So this population of people who are coming in for their first treatment are coming in with vitamin C levels down here. So we think, people are not taking it enough to compensate for the fact that they're not well. And many doctors will steer you away from taking supplements, but this is a nutrient that people are running out of. So with our infusion patients, we found that that the infusion, so these people getting very high dose, that after the first day of infusion, their plasma levels have gone right up, which is what we would expect. And from these patients, we've taken colonoscopy biopsy tissue, and then we get the surgery tissue. So at colonoscopy, the meter goes in, or the tube goes up, and it's got this little instrument channel, and out of this instrument channel comes this little thing, and it grabs little pieces of the tumour and for diagnosis, and we've also collected some of those. Then we've collected the tumours themselves, and from the tumour, so this is a normal bowel, we've collected a wedge from the tumour and some of the normal tissue as well, and within that wedge we can identify the outside, the middle and the centre of the tumour. And this is what we see with the vitamin C infusions. So people are not undergoing treatment, so the control people have levels of around about the middle levels of vitamin C, with less in the tumour than in the normal tissue. And when we look in the tumour at surgery, the centre of the tumour is really low. With the patients who've received vitamin C infusion, so at biopsy, they match the control group, and after surgery, their levels in the normal tissue have gone up, and so have the levels in the tumour. So we've been able to get the vitamin C into the tumour, and what we can see is that it's still really hard, even with those really high levels, to get it into the core. And so we think it's important, this is why the high dose might be important for people with cancer. If you want to get it into that core, looks like you might need some kind of infusion control. Though that dosing is absolutely not determined, and there needs to be a lot of study to work out what dose is best and how often and for whom, who would this work for and how often would we give it. And currently people are just run amok with this treatment and are dosing people with phenomenal doses at whenever they can afford. And that's not good practice, and we need some evidence to show just how do we use this. So in summary, most cancer patients don't have adequate plasma levels of vitamin C, and restoring those levels may greatly benefit their quality of life. There have been no serious side effects or adverse events with the infusions, and the high-dose infusion, we know, increases the ascorbate levels in plasma, normal tissue and tumours. And I'd just like to put in a plug for research teams. It's really hard to do this research, and we have a lot of people to thank, including our funders and particularly our patients who volunteer their time and their samples. And I'd just like to say it's really important to have a really good, tight study team. Our team includes clinicians, tissue bank curators, registrars, clinical trials units people, and laboratory people. And so, you need to bring a big team and a diverse team together in order to collect even very fundamental information. So I'll leave it there. Thank you.
In case there's any questions. Just before we take a break, are there any questions while we have Margreet here?
There may be questions for the other speakers too. How it affects HIF1? Yeah. Yes, I do. I left it out of this talk because it's relatively complicated. HIF1 is turned off by a group of enzymes called hydroxylases. So these enzymes hydroxylate a number of particular amino acids on the chain, and when they're hydroxylated, the protein's targeted for degradation. Those enzymes need vitamin C to work, like a lot of other enzymes in the same family, like the enzymes that make collagen for skin and many other hydroxylases. When the vitamin C levels are low, those enzymes don't work well. They respond too quickly, and the HIF1 comes on. It's at a protein level.
Yep.
Evidently, that going to have an infusion is a big decision, but taking vitamin C tablets is very easy.
That's right.
A purpose to do that?
There's always a purpose to do that, and I think that's why I put up the information about like the levels in people who are ill. Every patient group we've looked at looks like that, and overseas people find the same thing. It's a known effect, and so our current RDA, what you're supposed to get from food is enough for when you're not sick, but when you're sick, your body needs more. And if we were animals who make their own vitamin C, they increase their synthesis rate. When an animal gets sick, it increases its synthesis rate up to 100-fold to compensate. They keep their blood levels at saturation levels no matter what. And so we can't do that. And so we're currently kind of looking at how do we get this message out to people that, your daily intake needs to vary if you're sick. I mean, when we get a cold, what do we all do? I think, well, most of us probably intuitively go to the chemist and buy some vitamin C tablets, and we take those, and we think, well, we don't know whether they're doing any good, but many people say, oh, I feel better. And so it is, and actually it turns out when you have a cold, your levels will deplete. And the worse the respiratory illness, the lower they'll go. So there's a time for supplements. When you're normally well, we always say food first. Absolutely, food first. That's always my message. But there are times when it's really hard to get it from food, and so it really does help. And there's a huge knock-on effect in terms of quality of life.
I think maybe one last question. Sorry, here.
What about eating a lot of citrus, which is what I do all the time? Is that sufficient?
It's about milligrams actually. So 200 to 400 or 500 milligrams a day of intake should see you at daily, because it's a water-soluble thing in your body and it gets turned over quite quickly. So that should see, you can get that from food, providing you're eating from the top of the list, what I call the top of the list are foods that have high vitamin C levels. Capsicums, kiwi fruit, citrus. Providing you're eating from that part of the list, at least 1 or 2 things a day, you'll get about 500 milligrams a day. If you think you're eating fruit and vegetables, and your vegetable is a carrot, and your fruit's a banana, then you're nowhere near that. So they're not all equal.
Right. Thank you very much to Margreet Vissers for that fascinating